Hi, my name is Jordan Petrie and I will be teaching on organophosphate toxicity. Now, you may hear organophosphate toxicity and think, this will never happen. Why is this crazy student teaching about it? Organophosphate toxicity is one of those zebras and I'm likely never going to see this in practice, so why? My theory is the more you know about the zebra, the more you're likely to catch it and you might just save someone's life. So organophosphate toxicity prevalence is notable. Worldwide, there are actually 3 million exposures per year, resulting in 300,000 fatalities. In the US, there are over 8,000 with 15 fatalities. As with some zebras, so to speak, you may never come across them, although I've actually had one patient with organophosphate toxicity. The ER physician noted the patient's signs and symptoms and within 5 minutes knew to ask about exposure to pesticides. And we're in a pretty big city where I work, and so the thought seemed pretty unlikely, but the patient ended up reporting being sprayed with pesticides or spraying pesticides for the last 3 days and was ultimately diagnosed with organophosphate toxicity. Where are they typically found? So organophosphates are found in some insecticides, so you should have heightened awareness or concern in rural farming communities. They're also found in some household roach and ant sprays like Raid and Black Flag. They can be found on contaminated fruit, flour, cooking oil, or contaminated clothes. And there are a number of patients that come in because they purposefully self-poison as a suicide attempt, so you should remember that. How do they enter the body? So they're easily absorbed through the skin, lungs, and GI tract. But what are they going to do when they're in there? Why do we care? So organophosphates are cholinesterase inhibitors. Cholinesterase or acetylcholinesterase, you can use those two words interchangeably, function by breaking down acetylcholine after it's released from a neuron. So if you're inhibiting it, acetylcholine will build up in the neuronal synapses. So that's the synapse between two neurons, and then also build up in the neuromuscular junction, which is the synapse between a neuron and skeletal muscle cell. So here we see a pre- and postsynaptic neuron, and we can see that acetylcholine is leaving one normally and binding to the receptor on another normally. Here we see acetylcholinesterase represented by the lightning bolt, which works by breaking down acetylcholine at the synapse. So if this with organophosphate toxicity, this acetylcholinesterase is inhibited. So then acetylcholine is going to overwhelm the synapse. So we're going to have this abundance of acetylcholine. But why do we care? Acetylcholine is a neurotransmitter found in the central and peripheral nervous system, at neuromuscular junctions, and in red blood cells. In the peripheral nervous system, acetylcholine activates muscles and is a major neurotransmitter of the autonomic nervous system. In the central nervous system, acetylcholine causes excitatory actions. The parasympathetic nervous system uses acetylcholine pre- and postsynaptically, so is often thought of as the cholinergic system. Acetylcholine binds to two different cholinergic receptors, and those are known as the nicotinic and the muscarinic receptors. With organophosphate toxicity, acetylcholine breakdown is inhibited, like we talked about, and overpopulation of the acetylcholine overstimulates these muscarinic and nicotinic receptors. The muscarinic receptors are found in the parasympathetic nervous system, which we remember is part of the autonomic nervous system and serves to rest and digest. And the nicotinic receptors are mostly found in the neuromuscular junction and autonomic ganglia. So if we want to break down these receptors, muscarinic receptors are found in different areas. M1, there's actually 5 different kinds, but usually people focus on the first 3. So we're going to talk about the first 3. And M1 acetylcholine receptor is located in the central nervous system and the enteric system. So you can remember that because the brain is the most important organ in the body, M1. M2 is located in the heart, second most important organ in the body, and then N3 is located everywhere else. One easy way of remembering what these muscarinic receptors are doing, or what's going to happen when they're activated, is the mnemonic dumbbells, which stands for, we're going to see defecation, urination, meiosis, or pupillary constriction, pinpoint pupils. There's 3 B's: bronchorrhea, or excess sputum, bronchospasm, bradycardia, emesis, because of the increased gastric secretions. We'll see lacrimation and salivation. The nicotinic receptors are where we're going to see the central nervous system effects, like fasciculations, muscle weakness, paralysis that is so severe that it's actually been compared to succinylcholine effects. So if you've ever intubated someone and used succinylcholine to paralyze them, it's going to be that severe. Central respiratory depression, we'll see lethargy, seizures, and coma. So what are we actually going to see with our patient? Most of the time, you'll see the signs and symptoms appear fairly quickly within 3 hours with the oral or respiratory ingestion or exposure, and then 12 hours for skin exposure, with some delayed cases of 5 to 30 days, but less commonly delayed. So we're looking at, again, cholinergic toxicity or excess, because organophosphates inhibit the acetylcholinesterase, which is normally responsible for breaking down released acetylcholine, so we end up with too much acetylcholine. And I remember in nursing school, my professor taught me that anticholinergic drugs, so opposite of what we're talking about, produce no P, or no C, no P, no spit, no, you can probably guess what comes next. It rhymes with spit and means bowel movement. So consequently, cholinergic drugs will result in the opposite, so a really wet picture, as discussed earlier. So putting it all together, we can view cardiac, respiratory, and neurological manifestations. With cardiac, early signs include tachycardia, hypertension, and then finally we'll start to see the arrhythmias, the heart blocks, the bradycardia, and possibly prolonged QTCs. With respiratory, we will see rhinorrhea, excessive secretions, bronchoconstriction, wheezing and dyspnea, chest tightness, tachypnea, and then finally respiratory depression. And as we're moving through this, think about differential diagnoses or other things that you may misdiagnose the patient with, because you think, oh, that could be asthma or a viral syndrome, etc., because they have very similar signs and symptoms. Neurologically, we can see decreased responsiveness, decreased deep tendon reflexes, cranial nerve abnormalities, muscle weakness, meiosis, headache, convulsions, loss of consciousness, and finally coma. So if your patient is conscious when they arrive, they will be just like this poor guy in the picture who's sweating, has the runny nose, increased tears, pinpoint pupils, frothy mouth, vomiting, urination, diarrhea, and bradycardia. How are we going to diagnose this patient? So diagnosis is typically made by a clinical presentation and a history, but cholinesterase can be found in red blood cells, so we can measure plasma pseudocholinesterase levels, the PIC levels, which is the most common way to check, or cholinesterase in erythrocytes can also be checked. We would expect to see decreased PSE levels as we understand organophosphates inhibit cholinesterase. So that would be the primary test you would use to differentiate this from something else. Sometimes organophosphates smell like petroleum or garlic. In one case study that I read, a child was brought into an emergency room for vomiting and decreased level of consciousness that presented with an unpleasant odor. Quickly, he was followed by his sister, who came in with the same signs and symptoms. So after both of the patients were stabilized, they discovered that the children had been playing in the bathroom and spraying each other with a spray bottle filled with insecticide. All of their laboratory findings ended up being normal, except for the decreased PCE levels. In another study, it was found that those with organophosphate toxicity also had raised levels of random blood sugar, BUN creatinine, hepatic enzymes, and amylase. So I would run these tests and expect to possibly see elevations in those. How are we going to manage this patient and treat this patient? So clinical management will be focused on resuscitation, obviously first, focusing on the airway and oxygenation. If intubation is necessary, succinylcholine should not be used because it is metabolized by acetylcholinesterase. So obviously we're inhibiting acetylcholinesterase with organophosphate toxicity, so it's not going to do anything. Clothes should be decontaminated and the body should be washed with soap and water because we need to remove the problem from the patient. We don't need to pass that on to anyone else. Prognosis is generally considered poor if the GCS score is less than 13. We should treat acid-base imbalances as these have been shown to be predictors of patient outcomes. We need to treat the signs and symptoms. Pharmacologically, muscarinic antagonists like atropine can be used. Oximes such as pralidoxime can sometimes reactivate acetylcholinesterase and be used as an antidote. But that is if the problem is not irreversible already. It has been noted that organophosphates are the most commonly used insecticides in the US and around the world, and may be potentially used as a nerve agent in the future. So most of our future education related to organophosphate toxicity lies in prevention, such as washing fruits and vegetables and educating farm workers to wear proper PPE and remove and clean properly their clothes, and educating those traveling overseas, as well as educating parents about keeping their household products like that in a safe place, and educating their children not to be using those for any other reason. It was found in a study that rats who survived organophosphate toxicity suffered from depression and anxiety and memory impairment long term. So if someone were to come in with this disease process and we have already solved the acute issues at hand, interventions related to health and promotion may include monitoring for mental health issues such as depression and cognitive changes. Additionally, it was found that chronic prenatal exposure leads to IQ deficits by age 7. This study was in an agricultural setting, so proper exposure prevention education is a key intervention for those living in agricultural areas that may be either acutely or chronically exposed to organophosphates. Differential diagnoses could include ingestion of many things, including nerve agents, carbamate insecticides, or medicinal carbamate, nicotine, or mushrooms. These all act very similarly to organophosphate toxicity in that they can cause cholinergic toxicity. So any of these causes we should consider. Patients may be more commonly misdiagnosed due to their signs and symptoms with viral syndrome or some kind of viral process such as gastroenteritis or the flu, because again, they're vomiting, they're lethargic, they kind of have a systemic issue going on. So we really need to tease out the history and consider other lab work when trying to sort through what could be going on. Asthma or respiratory distress and failure should be a differential diagnosis because, again, your patient's coming in maybe wheezing, lethargic, and they could have respiratory distress due to their from a neurological cause. Intoxication, because they're going to be vomiting, diarrhea, sweaty, lethargic, altered, neurologically not intact. So that is also something to consider. But again, we need to talk about the history, the entire clinical presentation, and the lab work. Because you're not going to see those low PCE levels with these. And as a side note, kind of full picture, falsely low cholinesterase levels can be found in pernicious anemia and hemoglobinopathies. So these patients could also come in lethargic and also have the low cholinesterase levels. So we would need to look at the whole picture to make sure we're not misdiagnosing them with something like that. So that's it. I have 3 multiple choice questions for you to answer to kind of tie it all together. So which is not true regarding organophosphate toxicity? B is not true because organophosphates are going to increase the acetylcholine at the synapse. Which statement is true? So A is true. Acetylcholine does bind to nicotinic and muscarinic receptors. Muscarinic receptor activation causes a wet picture, not a dry picture. Nicotinic receptors are found at the neuromuscular junction and the autonomic ganglia. And then cholinergic toxicity typically presents with pupillary constriction, not dilation. And finally, what statement is false regarding organophosphate toxicity? So C is false because succinylcholine is an inappropriate drug when intubating a patient with organophosphate toxicity because it is metabolized by acetylcholinesterase, which is what we're inhibiting with organophosphate toxicity. So these are the references, and I hope you guys have a good day.